Connolly, now can we keep this tight? Is that okay?
I always keep it tight, Chair, actually. In relation to the State Claims Agency, I wanted to ask, my train of thought has gone. I've looked at your documentation, it's very good. I've read the chapter from the Controller and Auditor General back in 2012, and he sets out. And what impressed me was the State Claims Agency is thorough, in theory, and it does an investigation and carries out an investigation. First of all, back in 2012, in this chapter, only 40% of the claims that she came across had been previously reported as adverse clinical incidents. Is that right? That's in 2012. So even though there's an obligation on the various health organisations to report a clinical incident, only 40% reported. Has that figure changed for the better, given that that was 2012, given all the training, given the importance of disclosure? What is the figure now for the clinical events being reported?
Take that question. If I can just say, we're actually measuring it now in a slightly different way. The figure that you refer to is the number of claims that would previously have been reported as an incident. It is reasonable that some claims would not have previously been reported as an incident because it may not have been known at the time of the incident that there was an adverse outcome and that a subsequent claim would arise. So just looking specifically at the claims previously reported as an incident is not terribly helpful. So this year we've revised that, and we're now asking institutions to look at when a claim comes in, we can make an assessment of whether it should previously have been reported as an incident or not. Yes. And what we're trying to look at then is the difference between that which should have been reported and that which was actually reported. To look at that figure that you quoted, I've forgotten the figure you gave,
40%.
40%, in isolation is actually not that helpful.
Okay, just you can see how difficult it is now to bring accountability into a process.
Absolutely, and I understand this is a complex area.
A 2012 chapter. Yeah. Enterprises covered by the Clinical Indemnity Scheme have a statutory obligation to report adverse clinical events to the State's Claims Agency.
Absolutely, yeah.
While it is likely that only a small proportion of adverse clinical events will lead to a claim, nevertheless, there is still a statutory obligation to report. At that point, 40%. Let's take 13, 14, 15, 16. What was the percentage of reporting?
I don't know if I can give you that figure offhand. I don't have it.
Do you know if it improved?
It had improved, but what I need to clarify is that it's not of itself a useful indicator.
But it was a useful indication at that point.
No, it was. But we've recognised that it has deficiencies. Okay. And on the basis of that, we've developed a modified indicator. All right.
In relation to Galway University Hospital, how many clinical events have been notified in the last number of years? Let's take 16.
We wouldn't, Deputy, have that information with us, at a meeting like this.
Is that available publicly? Is that available afterwards in a note?
Yes, we know from the NIMS system, the National Incident Management System, in respect of any hospital, the number of incidents it reports in a particular year.
You see, what I'm trying to find out here, how does one improve the system, even if we move away from the very specific issue that we looked at today? Generally, how can it be improved if this system that was reported in 12, where it was a 40% reporting, you've no details on it. Now you're telling me you've changed the system because it wasn't a very reliable indicator.
Yeah, and you're right, Deputy. We are trying to improve reporting, generally in relation to adverse event reporting in healthcare systems. It's never, 100% obviously or anything like it.
I just want to know, has the system improved so much that more than 40% of serious clinical incidents are being reported? I'm thinking of Galway. I'm thinking of publicity.
Just to give you
just where inappropriate procedure was carried out. This is all public knowledge. Inappropriate procedure carried out by a surgeon. Was that reported as a major clinical event?
Well, just to give you a statistic in terms of improvement, in the last 3 years we've gone from 130,000 incidents reported on an annual basis to 170,000.
130?
From 130 to 170. And we're, at the moment, as my colleague has said, we're in the process of this sending out this new indicator, and we are writing out to every hospital and community health area in relation to incident notification.
I wish we had more time and I'd come back to it. Sorry, I got 2 minutes. Just let me finish my question, please.
Yeah, that's it.
My question is in relation to the memo, where this wasn't regarded as a serious patient. Two things emerged in this. One was that it wasn't. The memo says it is not a patient safety incident, but rather a reflection of the known limitations to the current screening test. Question, do you still hold to that view? Do you agree with that, or have you changed your mind? Number two, the National Screening Service has assured the Department that no quality issues has arisen in relation to the US laboratory, which performed the test in 2011. We know now that 2 laboratories are being sued in 11 cases that we know about. And there's no quality issue in relation to those laboratories. And then tied in with that, and you say that the State Claims Agency has an ethical and all of that, and yet the solicitors for the lab gave an expert opinion. Sorry? I've run out of time. I'm going to leave it like that because I want to come in on the other matter. But the 2 issues I've mentioned there, the quality. It's difficult when the chair is talking to you. You lose your train of thought in the afternoon on Thursday. Yeah. Sorry, I want an answer if you don't mind, Chair. Thanks.
So, based on the information that we now have, I do consider this to be a patient safety issue.
Thank you. Thank you. And issues in relation to the laboratories? Quality issues?
So, this is going to have to be
sorted out in the
perfectly gone through, but having a case against you,
I understand.
It doesn't in and of itself say that there's a quality
but
issue.
In the meantime, while we're waiting, the tests are going to go to these laboratories. The tests are going to continue to go to these laboratories.
But Mr. Breen will tell us that there's up to almost 3,000 cases under the clinical indemnity scheme. Okay. That is healthcare.
Okay, all right.
Okay,
thanks.
Deputy McSharry.
Back again to basics. And the question was asked by me of Mr. O'Brien, when did he find out? He clearly said early 16. And we get a memo now, March 16. So he knew as far as back as March 16. There is no date on that memo, and there's no signature on that memo. So that's extraordinary. Was the Department aware of this memo or any of the other 2 memos?
The Director General said we were aware of a memo this morning.
No, I know. Sorry, I heard him saying that he got a memo. I didn't hear anything.
No,
else.
he did. He indicated that a memo, or at least something around that time, a version or some type of correspondence or communication with the Department took place. And I have asked in the people who are doing the trawl in the Department to zero in on that and see if we can identify whether we have it.
The Department was possibly aware of this March memo. Does that mean, Dr. Houlihan, you were possibly aware of it?
What I can tell you is I don't honestly know, and so I'm not going to say that I wasn't. Okay. But what I'll tell you is that the arrangements we have in place for engagements with the screening programme, and I don't want to delay you, but just so you understand, there is a means for us on about a monthly basis to sit down with the cancer control programme, and as part of that the screening service, and there is an ongoing dialogue in relation to issues as part of those kinds
Dr.
of engagements.
Houlihan, listen to me.
All of these issues.
Dr. Houlihan, it has taken the brave women to come forward. I've tried to stay away from emotions. It has taken a number of deaths.
Yeah.
Okay. It has taken, I don't know, many committees, and it has taken today to establish this is the first time that there was these memos. My simple question to you, as the head doctor in the department, were you aware of any of these memos? Yes or no?
I can't honestly recall the specifics of them, so I'm not going to say no. But the content, as I've read them, was that understanding. I knew that. Yes, I knew that there was clinical audit.
Oh, no. We're going to take this. We're going to take. Sorry, were you aware, Mr. Breslin?
I can't talk to any recall.
Okay, Dr. Houlihan. March 16, undated, unsigned. Did you stand over this? That there was a risk, not a risk to the lives of the women, nor to their health, but there was a risk that in communicating individual case reports to clinicians, that they would go forward to the media, the patients would, the women would, and there would be headlines. Screening did not diagnose my cancer. This was the risk that this memo is zoning in on, not the memo, not the risk to lives or health. Did you stand over that?
So I'm not standing over the memo in terms
No.
of its content and,
Okay.
and its writing and how it's presented, the
So
language it's
okay,
used.
okay. You don't know whether you were aware of this and saw this and thought it was okay or not at this point, are you?
I'm sorry, can you repeat the question? Apologies.
The contents are
Yes.
shocking. We'd agree that now. Were you aware of this memo? Did you stand over this, the content of this, as the chief medical doctor? Did you or did you not?
I can't honestly tell you that whether I saw this specific memo or not, but the general information that it includes is not in broad terms new information to me.
Well,
and given my understanding of screening programmes, given my understanding of, and if I'm in a position to do so, I can outline and explain why that is the case.
No, you can do that with the chair's time afterwards, perhaps. What I'm trying to get out,
I don't mean to take
what
your
I'm
time.
trying to get out here is, what I've heard repeatedly was a problem with communication. A communications issue, an isolated case, nobody knew, and then now we all know. I'm asking you as the chief doctor, the message in this has nothing to do with difficulties with cervical smears. It has to do with controlling the message, anticipating screaming headlines. That is the risk that's been discussed here.
I can point out, if it's helpful, that people who are charged with, in both policy and operational delivery terms, operation of screening programmes, are genuinely concerned, and this is an international phenomenon, about the way and the manner and the means in which communication of false negatives, when they do occur, impact on reputations of programmes. That's a genuine concern. The literature is full of that. That's not me kind of suggesting. So there's nothing different in that.
The memos, I've tried to avoid it making conclusions all day. I've tried to listen with an open mind. At this point, I'm finding it extremely difficult. I've read the 3 memos very quickly. It's clear that there's a containment solution going on here. Would you agree with that
no,
now?
I would disagree with that.
Oh, you disagree? Okay.
And the reason I'm going to say I disagree is because, and I did say it earlier on, I'm happy to say it again, that my understanding of screening programmes at a European level, and I've taken steps, and I would understand this from my own knowledge, is that open disclosure policies, regrettably, are not well developed. Here was evidence that our screening programme was attempting to put in place an arrangement to look back where audit was not a standard across all of those programmes, and to feed back that information. What we now know is that that didn't work.
No, what we know is there's a memo in March to Mr. O'Brien, undated and unsigned, except for a general month. We know that you, as the chief doctor in the department, is not sure whether you saw this, and you're not telling us whether you disagree with the message that's in this to control the message to the media. Not alarm bells about the women.
I didn't quite say that.
Okay, what did you say?
I didn't quite say that.
What did you say?
So I would be very sensitive about any sense in which messages are being controlled and so on. What I'm simply saying is what that appears to be in language that I would not use.
Well, did you tell them not to?
But just to be clear, just to finish the point I was going to make, that it does advert to what is a known and an international phenomenon of general concern for the reputation of screening programmes, the uptake of screening programmes, when harms that arise come to public prominence.
There's a serious problem here with concerns about reputation as opposed to women's lives and women's health. But just let me stick. We have 2 other memos in July. Both are dated July. No specific date in July. There are contradictions between the 2. For example, over 1,200 cases in one note. In the other July, over 1,100. In relation to letters, to date, a total of 86 letters went out, with 200 more to go. In the other July note, 56 letters have gone out. Now, I don't know why there are 2 sort of similar notes. Were you aware of those?
I don't know the answer to that question right now.
At this point, that we're looking at these, just now, please. At this point, would you have serious concerns about these notes and the nature of the content of them? Would you have, as the Chief Medical Officer, serious concerns about the content of these 3 memos?
What I would say to you, and I'm going to use my own language if that's okay. What I would say to you in relation is, it isn't giving me new information that gives me a concern on the basis of what it's saying about the standard of performance of the screening programme at that time. It's giving me in language that I wouldn't use, and when I look back now and see the language and how it might be interpreted, I can see exactly what you're saying, and I understand exactly why you're saying it. That the arrangements that were put in train in relation to clinical audit, the arrangements that were put in place in relation to feeding information back to patients, I would have seen at that point in time those as developments that were ahead of most other countries in relation to screening.
No, Dr. Hoolan,
that's how I'm interpreting it.
No, I'm not allowing you to go down the road of telling me. No, please, I'm not allowing you at this point to go down the route of telling me how good the service is. That's not for here. What's for here is accountability. That's what's for here.
But it is important that
you are asking him about the memo
and whether he can stand over it.
Yeah, and I'm just saying, because again, I've read through it. There are different parts to the memo. There are parts that actually are giving reassurance on the quality of the programme. And that is also in the memo.
Mr. Breslin, are you standing over these 3 memos?
What I'm saying to you is,
Mr. Breslin,
you've asked him a question, which is, would it raise concerns for the programme?
Mr. Breslin, I'm asking you now, and I asked Dr. Hoolan the same thing. Are you standing over the content of these 3 memos?
I'm not standing over the content. I've said earlier that there are important aspects to this that hopefully are covered in the communications protocol that would ground this in the women who are going to be communicated with. That would be important.
Sweet Jesus, honestly, at this point, I've really tried. Please, I've really tried. I think you have no concept of the damage that has been done. Leave that aside. You have no concept of accountability. We have 3 memos with no dates. We have 1 memo with no signature. We have a memo addressed to somebody that was on the directorship of the Health Board. You were on the directorship? Isn't that correct, Mr. Crowley? You were on the directorship, and Mr. Woods, and the person to whom this note was addressed is also on the directorship. Isn't that right? This, on behalf of Dr. Stephanie O'Keefe, National Director Health and Wellbeing, she was also on the directorate? Was this raised at the directorate?
But all of the things you've said also required to ask the question. Because the data is changing, are these working drafts? Are they actual? Did we get is there a final memo here? Are they working drafts? Was somebody still working on the situation?
Do you know,
we actually haven't got this in the door.
For different points in time.
But we need to establish that.
Well, in fairness, Secretary General, we asked for the memo today. Yes. So we can only work on what we have here today. If there was a final memo, it should have been provided. What we're working off today is all we can work off. We can't deal in.
So I appreciate that, and all. Maybe I'm not being helpful. All I'm doing is trying to interpret it in real time, just as yourself.
Deputy O'Brien.
I was in the middle of the sentence, Chair. I was in the middle. Very quickly. I asked the question not about a memo. I asked, when did Mr. O'Brien become aware of the situation? This was Mr. O'Brien's answer. He said a memo. It turns out 3 memos. So it's in that context I'm asking you the question. And my final question was in relation to the laboratories. There was obviously discussion with the laboratories who had difficulties that the women would be communicated with. Have you seen that in the memos?
Yes.
And so the laboratories' interests were of the utmost concern to whoever wrote this memo.
Although I think it says we're going ahead, that won't stop us.
Deputy O'Brien.